Well, welcome all to the KAT6A conference. I can't remember, is this the fifth one or the fourth? Fourth, okay. And I've been to all of them. So, because I've been to all of them and because I have a limited repertoire of research in KAT6A and KAT6B, much less KAT6B, I've decided not to repeat all the slides again, which many of you have seen. Some of you might not have, but this is really more an open forum. Is that better? An open forum to ask questions. I do have I have a couple of slides to just summarize what our understanding is about the biochemistry that we see and how we treat it. So I'm a biochemical geneticist, and for the past 40 years, my work has been to find treatments for a metabolic abnormality. So I'm going to first summarize what we know so far, and that might prompt some questions, and then also what kind of treatments we have. I have some slides that if a question comes up, I can show some pictures about it. But it's basically an open forum. You can ask anything that you want. But I just wanted to get people who haven't been here before up to speed with what we know. Okay. So again, I study the metabolism, the biochemistry in patients of a wide variety of diseases. And the first thing I found, or one of the things that we do is we look at amino acid levels in blood. Now they come from protein and they go to make new protein. And it just happens to be, for a good reason, that amino acids, their levels in blood are regulated by mitochondria. And therefore, looking at the amino acid profile, and I've developed a way to make it more sensitive. Looking at the amino acid profile, it tells you a great deal about what the mitochondria are doing. So that's the first test that I had done, or the first test that I'd done on more than just one patient. And indeed, there are abnormalities in amino acids, in particular citrulline and asparagine, sometimes arginine and ornithine. We don't know exactly why this occurs, but it has something to do with how ammonia is handled. That is, amino acids break down. When they are broken down, they turn into ammonia, and the ammonia is then turned into urea. And the urea cycle is disturbed in some way, but it doesn't cause the kind of pathology that we see in classic disorders of the urea cycle. And then having heard more about KAT6A, and I had mentioned before, finding that there's a high incidence of dysmotility, that the gut doesn't work well. And it can be so severe that there can be frank obstruction, a volvulus, a turning over, the gut turns over on itself, intestines, or intussusception, which is where one part of the intestine telescopes over the other, and that's a medical emergency. And there's no disorder I know of that has such a high frequency of that particular type of damage that can occur from dysmotility. But as I said, my experience in dysmotility and other mitochondrial disorders shows that it's usually due to a deficiency of citrate. The citrate is what mitochondria make. It's one of the major the major way by which mitochondria take all the different food substances and produce most of the food substances and make citrate, citric acid, as you get in any citrus fruit, and that is a major source of energy and other functions of the mitochondria. So that's very low. I really don't know any other condition where the citric acid is low so consistently, but it then tells me that it's a characteristic of the mitochondrial dysfunction. And I'm pointing these out in part about the mitochondrial dysfunction because I'm sure you've had the experience with geneticists who say flatly KAT6A is not a mitochondrial disease. And it's not a classical one, but certainly there's significant mitochondrial dysfunction. The mitochondria aren't working right. And we can use some of the methods we use to treat mitochondrial problems to treat KAT6A. So the best I can say is an atypical mitochondrial disease, but it can be treated just like any other. And it's unfortunate that many of my colleagues are, because it doesn't fit criteria for classical mitochondrial disease, they say it's not something we can deal with. I mentioned also methionine deficiency that, actually I will show on one slide here why it occurs. These are fibroblasts, skin cells from a severe mitochondrial disease, Lee syndrome. And and this shows, they're looking at the balance of substrate, compounds that go in and go out of mitochondria. So the net substrate uptake, so the mitochondria are taken in compared to the wild type, more of the substances with a black line, and you see the compound that is most taken up is methionine, and that's why we find the methionine deficiency in KAT6A. And I've found in another condition, another mitochondrial disease I study, that it's the creatine that is oversynthesized. Creatine requires methionine and as the last step in its synthesis. And in this other condition that I've studied to some degree, they have 5 to 10 times more. They make 5 to 10 times more creatine. So that depletes the methionine. And the way we monitor this in KAT6A and KAT6B, though I haven't seen it there, is by the red cell size. Before the bone marrow is severely affected, the red cell size starts to increase. And I think it's the next slide, yes. And this is what happens. This is a severe mitochondrial disease where this happens more often. And this shows that the red cell size over a number of years gradually was increasing because the mitochondria are becoming more and more damaged. And finally, the red cell size went above normal, and the child became metabolically unstable. And I started methionine, and the red cell size dropped as fast as it could. That is, a red cell lasts about 120 days. So the bone marrow essentially instantly corrected. So this is what I've seen, and probably there's some degree of this in 25% of patients with KAT6A. Again, I've only done biochemical testing on about 7 or 8 KAT6B, and there is some overlap, but I can't say much more about that. So then B vitamins, when there's a B vitamin, there's a secondary deficiency of B vitamins, that when amino acid metabolism is distorted, things go down the wrong pathway, and it sometimes will overuse, it will require more B6 to keep those other pathways going. So B6 deficiency is particularly common, not as much in KAT6A as other mitochondrial problems. And then there is clearly one can develop a more typical type of mitochondrial disease or mitochondrial dysfunction. And it occurs with age, which makes sense, as I showed you, that young man who had a methionine deficiency and the rising red cell size, you can see that the red cell size went up gradually, and that's cumulative mitochondrial damage. And we see the same process in KAT6A. And therefore, in some patients, it's been clearly abnormal and requires what we use for standard mitochondrial treatment, which is to protect. What's going on is so-called free radical damage of mitochondria. So we use a particular combination of antioxidants that protect the mitochondria from that free radical damage. And it works extremely well in KAT6A, and it works in most other mitochondrial diseases too. So I'm just saying that KAT6A can benefit from these years of experience with treating the mitochondrial dysfunction. So it's one sign that you'll see in some patients with KAT6A is something that's seen that is a classic sign of other mitochondrial disorders, and that's an increase in lactic acid. It's never severe, but it's distinctly abnormal in some patients. So I should say there's a great deal of variability that is some young children with KAT6A can have significant mitochondrial dysfunction that requires some treatment, and sometimes it's clearly something that builds up over time. So for most adolescents, I say at least half of adolescents and adults with KAT6A will have mitochondrial dysfunction that requires treatment. So the hope is, and so far, though I don't have such it appears to be that if a child has no signs of mitochondrial dysfunction, that treating with carnitine and pantothenic acid, which makes carnitine work better, and what that does, it stimulates the carnitine and pantothenic acid together, and I'll show this here, stimulate the synthesis. So this enzyme here, oh, this one doesn't have an enzyme. Let me go back. Anyway, so there's an enzyme right at this point, pyruvate dehydrogenase, that exists outside the nucleus and inside the nucleus. It's the same enzyme. And we have diseases where that enzyme is deficient. And carnitine and pantothenic acid work very nicely to increase the activity of that enzyme. I'll skip how that works, but it works very nicely. And so the idea is that if we can, and it seems if we can increase the amount of acetyl-CoA, so the pyruvate dehydrogenase increases the amount of acetyl-CoA that's available for the good copy of KAT6A to use. So in effect, we boost the level of acetyl-CoA in the nucleus by giving pantothenic acid and carnitine, and that increases the degree of acetylation. It's in the animal models, it can be measured, as Dr. Voss has shown, but it certainly works clinically in KAT6A. So, and then how do we treat this? I've already touched on some of these. So we activate the pyruvate dehydrogenase citrate is with the dysmotility, and I should say that from my experience as a biochemist treating these conditions, it's been one of the more remarkable clinical effects to see what adding citrate does. And I'm sure some of the families here have experienced it. Most children with KAT6A will have some dysmotility. Maybe it's just bad constipation, but it can be very severe and can cause many hospitalizations. So it does work, and it's very satisfying from my standpoint to just say, oh, take tricitrates, and the child is tremendously better. So we look for those kind of treatments. I think I've touched on most of the other things here. There is, in terms of fasting stress, so when a person is fasting, mitochondria have to work harder, or at least differently. So in other mitochondrial disorders, overnight fasting, just sleeping overnight 10 hours, by the morning there is significant stress, so to speak, that the mitochondria are not working well enough to do all the metabolic work that has to be done. And simply by giving cornstarch at bedtime, which is easier said than done for young children. So giving cornstarch at bedtime, basically the cornstarch is just very slowly absorbed. Glucose is in and out of your metabolism quickly. Cornstarch is just slowly broken down, and it can extend, it can effectively shorten the overnight fasting period by 4 to 6 hours. So the child sleeping overnight is only really fasting for 6 hours. And that's extremely beneficial in classical mitochondrial diseases, and it has some role in KAT6A. This whole issue of the microbiome is clearly, it's better understood now that the microbiome in the gut, that one of the major functions of the microbiome is to produce these short-chain fatty acids. Like not valproic acid. Thank you. So valproic acid is a short-chain, branch-chain fatty acid, but there are other, which is not made by gut bacteria, but the common ones that are made by gut bacteria are 3 carbons, 4 carbons, propionate, butyrate. And these are, as Dr. Voss has explained, these can function, the enzymes, KAT6A, can use these other short-chain fatty acids. Acetyl-CoA is 2 carbons, propionate 3, butyrate 4, and they all will acetylate with the right enzyme. These lysines in histones. So there are 2 things to think of. One is that if we are increasing the production of acetyl-CoA by giving carnitine pantothenic acid, in one sense we are reducing the availability by competition of propionate that is made by the gut. So it's a difficult question to answer in patients. But the idea is that the ability of KAT6A to add propionate to molecules is to histones is also reduced. So that's another aspect of treatment that is yet to be explored. And the last thing I'll say is that it turns out that isoleucine is an amino acid that I use clinically in specific disorders. So I have actually a lot of experience using that. And it's the major source of propionate for histone modification. And it's very safe in general. It's just the same, it's giving a lot more of isoleucine, maybe twice as much isoleucine as one would have in the diet. But it is, in these other conditions that I treat, it's very effective, and it doesn't lose its efficacy over many years. So that's something that we need to explore perhaps on an individual basis. Again, I have a lot of experience with it. It's quite safe, and but we need to set up ways of determining if it has an effect. It's not going to be as easy. It's much easier to show these things in mouse models than it is in a person. And I don't want to jump into isoleucine treatment without some better understanding of the effects that it might have. But it could turn out to be a very, very simple way of restoring the propionylation, as the term is, of histones. at the same time that we're increasing the aceleration. Okay, so that's my spiel. Time for questions.